So at this point, I'd like to introduce our first speaker. Our first speaker is Dr. Camara Phyllis Jones. She has a very strong background in this topic, and we all look forward to her presentation. Dr. Phyllis Jones is a family physician and epidemiologist whose work focuses on naming, measuring, and addressing the impacts of racism on the health and well-being of the nation. She is a past president of the American Public Health Association and was in 2019 and 2020 the Evelyn Green Davis Fellow at the Radcliffe Institute for Advanced Study at Harvard University. She has served on the faculty of Harvard School of Public Health, the Morehouse School of Medicine, and Rollins School of Public Health, and as a medical officer at the Centers for Disease Control and Prevention. Without further ado, let me welcome Dr. Phyllis Jones.
Thank you, Dr. Pronk, and I am delighted to be here as part of this roundtable proceedings. I am coming not with expertise in obesity, but with expertise in talking about naming, measuring, and addressing the impacts of racism on the health and well-being of the nation. So what I'd like to do this morning is to talk about what do racism denial and the obesity epidemic have in common. And our roadmap is going to be around, in my only 20 minutes of comments, framing the work. So I'm going to give you a way of understanding that racism exists with one of my allegories. I'm going to talk about the obesity epidemic and how we need to understand that by widening our gaze. Then I'm going to very quickly help us understand different levels of health intervention with a cliff analogy, and then finally braid these strands to talk about what do race and weight status have in common? What does racism have to do with, structured stuff around weight status? And then how do racism denial and the obesity epidemic really have lots of things in common? So lots of braiding of the strands. To start with, let me share this story that I call Dual Reality, a Restaurant Saga. One of the allegories based on something that happened in my own real life, things that I've seen with my own real eyes. And let me tell you that the moral of this story is that racism exists. So what happened? Here I was, first-year medical student, studious as ever. Saturday, woke up early in the morning studying, and here it is mid-afternoon, and I am still studying. And some friends come over. And do they distract me from my studies? Oh, no, we all get to studying long and hard. And now it's getting late and we're getting hungry. And I have no food in the apartment, which was so typical of me that my friends excused me. Never mind, Camara. But they said, we are hungry. Let's go into town and find something to eat. So we do. We walk into town and we find a restaurant and we walk in and we sit down. And the menus are presented, and we order our food, and the food is served, and here we are eating. So not the story about racism exists that you thought I was going to tell when I was talking about a restaurant, but hold your horses. As we sat there eating, I looked across the room, and I noticed a sign that was a startling revelation to me about racism. So now perhaps I've intrigued you, and you're wondering, Dr. Jones, what did the sign say? What did the sign say? The sign said, open. So now maybe I've lost some of you. So let me recap. Here we are sitting in a restaurant eating. I look across the room and I see a sign that says open. Thinking no more about it, I would assume that other hungry people could walk in, sit down, order their food and eat. But because I knew something about the two-sided nature of those signs, I recognized that indeed now the restaurant was closed due to the hour, but firmly closed. And that other hungry people, just a few feet away from me, but on the other side of that sign, would not be able to come in, sit down, order their food and eat. And that's when I understood that racism structures open, closed signs in our society. That racism structures, if you will, a dual reality. And for those who are sitting inside the restaurant at the table of opportunity eating, and they look up and they see a sign that says open, they don't even recognize that there's a two-sided sign going on, because it's difficult for any of us to recognize a system of inequity that privileges us. So, for example, it is difficult for men to recognize male privilege and sexism. It's difficult for white Americans to recognize white privilege and racism. In fact, it's difficult for all Americans to recognize our American privilege in the global context, although we should open our eyes and see it in full display right now with regard to our access to vaccines against COVID-19. But those on the outside, those are very well aware that there's a two-sided sign going on, because it proclaims closed to them, but they can look through the window and see people inside eating. So back inside the restaurant, to those who ask, is there really a two-sided sign? Does racism really exist? I say, I know it's hard for you to know when you only see open. In fact, that's part of your privilege, not to have to know. But once you do know, you can choose to act. So it's not a scary thing to name racism. It's actually an empowering thing to name racism. It doesn't even compel you to act, but it does equip you to act, so that if you care about those on the other side of the sign, which is an if, but if you do, why, you could even talk to the restaurant owner, who is, after all, inside with you. And you could say, restaurant owner, there are hungry people outside. Why don't you open the door, let them come in? You'll make more money. And oh, the conversations we could have. Or maybe what you'll do is pass food out through the window, or maybe you'll try to tear down the sign or break through the door. But at least what you won't be doing is sitting back saying, wonder why those people don't just come on in and sit down and eat, because you'll understand something about the two-sided nature of that sign. And I could go very deeply into this allegory at this point. Let me just say that I encourage all of you all to consider this question. How could people who were born inside the restaurant know something about the two-sided nature of that sign? I've actually started 3-hour conversations with that single question, because, of course, there are many ways to know. What I have to say right now is that I am heartened that more people who were born inside the restaurant have a sense of the two-sided nature of that sign, right? More people who maybe a year ago would have been sitting inside eating and saying, what are those people saying outside? Black Lives Matter? Don't they know all lives matter? Are now affirming, yes, Black Lives Matter. More people are saying the word racism, putting together the words structural racism, systemic racism. This is very important. But here is my warning. If we just say a thing, then 6 months from now, we may forget why we said that thing, because racism denial is so staunchly held in our society and is so seductive that if we just say a thing in 6 months, we may fall back into what I describe as the somnolence, the sleepiness of racism denial. So we must go beyond saying a thing to doing a thing. We must naming racism is essential, but it's necessary but insufficient. We must move into action. So understanding that racism is not just the sign, not just a two-sided sign creating a dual or multifaceted reality. It's the sign, it's the door, it's the lock. We need to be tearing down that sign, dismantling the lock, taking the door off the hinges, because if we start acting, we will not forget why we are acting. So that is just a story I say when I have 5 minutes to let people understand that, yes, racism exists, even if their whole life experience has proclaimed that this is the land of equal opportunity. Let me define racism and then bridge to obesity, the obesity epidemic, weight status, discrimination, and the like. So what is racism? When I say the word racism, I'm clear that I'm talking about a system. I'm not talking about an individual character flaw or a personal moral failing or even a psychiatric illness, as some people have suggested, although it can manifest in those ways. But I'm talking about a system of power. And a system of doing what? A system of doing two things, of structuring opportunity and assigning value. And on what basis is the opportunity structured? And on what basis is the value assigned? Based on the social interpretation of how one looks, which is what we call race. What are the impacts of this system of structuring opportunity and assigning value? Well, when we recognize that racism exists, we understand that racism unfairly disadvantages some individuals and communities. But it shouldn't take us long to recognize that every unfair disadvantage has its reciprocal unfair advantage, so that racism is also unfairly advantaging other individuals and communities. And that's the whole issue of unearned white privilege that we hardly ever talk about in this country, because it makes some people, especially some people who are living as white, uncomfortable. And I used to apologize and say, if you feel uncomfortable when I talk about how racism unfairly advantages other individuals and communities, how I name unearned white privilege, if you feel uncomfortable, I used to say, shake it off, stay with me, I'll tell you more stories. I don't apologize anymore. I'm not trying to make anybody uncomfortable, but if talking about these issues has made you uncomfortable, this is what I say: lean into that discomfort, because I have come to recognize that for each of us, the edge of our comfort is actually our growing edge. But there's a third impact of racism that many of us miss, and that is that racism saps the strength of the whole society through the waste of human resources. And I could go very deeply into that, but I don't have the time. I will say that right now I am recognizing of these three impacts of racism. Actually, that third one, how racism is sapping the strength of the whole society, is the one that I feel we need to lift up right now. We need to have more media stories about that. We need to have more data collection, more conversations around our dinner tables, so that more people are filled with a sense of urgency to dismantle that system and put in its place a system in which all people can know and develop to their full potentials. Now, those of you who are like, oh yeah, but this all sounds like a lot like weight bias and all, let me say that that definition I just gave you of racism can be generalized to be a definition of any system of structured inequity. So let's start, for example, with sexism. What is sexism? Well, that's a system of structuring opportunity and assigning value based on gender that unfairly disadvantages some, unfairly advantages others, and saps the strength of the whole society through the waste of human resources. And there are many axes of inequity operating in our society today, intersecting in communities and in individuals. And all of these are at least risk markers for how opportunity is structured and value is assigned, even as some of them, a smaller set, are actually risk factors in the progression to ill health. So weight status is one of these axes of inequity, just as race is an axis of inequity. And then the associated opportunity structures and value assignment, those are the systems of structured inequity. So that's my little primer on racism. So put that aside. We're going to tie this all together at the end. Now, what about obesity and weight perception? I went back and I found a presentation that I had done, I think in 2006 to 2009, so at least 10, 12 years ago, on this. But when I was at CDC, I took the CDC logo off of this because I'm not at CDC anymore. But these were my thoughts back then. And I think that this still applies. What we are doing in this country is we are characterizing an obesity epidemic. So we look at body mass index over 30. And what we are seeing is over time. Now, this is just made up data so it's not data. This is a schematic. But over time, we're seeing more and more people piling up on that other side, the high side of 30 BMI. But what is driving this obesity epidemic? What we're actually seeing are shifts in the population distribution of body mass index. And it is important for us to understand this. The insights here are that overweight and obesity are considered characteristics of high-risk individuals. But if we understood that distributions of body mass are characteristics of populations, it would give us more insight about what we need to do. The difference in the perspective is that we need to view this phenomenon not as an epidemic of obesity, a yes-no attribute of individuals on one side or the other of a cut point, but rather as a shift in population distributions of body mass, where this shift in perspectives has implications for our intervention strategies. The high-risk strategies targeted at individuals means that we want individuals who, we want them to avoid weight gain if they're affected by overweight, or to lose weight if they're affected by obesity. So now we're focusing in on personal diets and personal exercise. The success of these high risk strategies depend on perceptions of weight, They depend on motivation, depend on the availability of healthful resources. But population-based strategies are efforts to shift the distribution of body mass toward lower values now through social policy and environmental change, looking at neighborhoods and nutritious food and safe recreation in neighborhoods, or schools. And what can we do in schools in terms of snacks, school lunch, physical education, and on and on. We're going to have specialists talking to us today about some of these strategies. But workplaces in terms of stress reduction, physical activity, restaurants, caloric labeling. You see, I had way back in the 2000s limits on trans fat. Farms in terms of agricultural subsidies, transportation in terms of sidewalks, bicycle lanes, mass transit. And these population-based strategies also depend on something. They depend on leadership and political will. So finally, in the last few minutes that I have, so that was my overview on racism, and a little bit on racism denial, my overview on obesity and how we need to go from thinking about obesity, the obesity epidemic, as people on one side of a cut point to understanding shifts in population distributions. I want to very quickly now say, what does that mean in terms of how we think about interventions? And here I'm going to very quickly share what I call my cliff analogy that describes different levels of health intervention. This, if you've seen it before, this is going to be the 3-minute version. So here we go. Whoops! Somebody just fell off of the cliff of good health. And if that were you or somebody in your family, you would be delighted to find an ambulance at the bottom of the cliff to speed you on to care. But if we were concerned about other people who might come along that cliff, if we were concerned about population health, community health, public health, we might well ask ourselves, what could we put in place besides just stationing lots of ambulances at the bottom of the cliff? So somebody's going to say, I know we need a net halfway down to catch people before they get crunched up at the bottom, even if they fall. Good idea. Although nets do have holes in them, so some people might fall through the cracks, but we could even make that a trampoline halfway down, because there are no holes in a trampoline. But even if we had a trampoline halfway down that cliff, we might well find ourselves with lots of people just bouncing up and down at half functionality, not able to get back to the top of the cliff. So what else could we do as a health intervention? Well, we could put a fence at the edge of the cliff to keep people from falling in the first place. But that has to be a very strong fence if there's a lot of population pressure against it. What else could we do as a health intervention? We could move the population away from the edge of the cliff. Let me label these interventions that I've depicted so far, where the ambulance at the bottom of the cliff represents acute medical care and tertiary prevention. The net or trampoline halfway down, these are our safety net programs, often in social services, and secondary prevention, which is early detection, screening. The fence represents primary prevention, keeping bad things from happening in the first place. Moving the population away from the edge of the cliff is addressing the social determinants of health, addressing those determinants of health that are outside of the individual, beyond our individual genes, beyond our individual behaviors, the context of our lives, including individual contexts like poverty, so addressing poverty is an important way of moving the population away from the edge of the cliff. Neighborhood contexts like the lack of green space or crowded housing or poor schools or poisoned air or lack of available, healthy foods and the like. So addressing adverse neighborhood conditions, another way of addressing the social determinants of health. And in the conversation, we can talk about within the context of obesity, what this ambulance net fence and moving the population might represent. I just want to quickly finish giving you the layout. As useful as this diagram is, it does not yet talk about how health disparities arise. So this diagram, as I've given it to you so far, has a huge fatal flaw. So let's shift gears to very quickly talk about how health disparities arise on 3 levels. And especially when you're talking about racial ethnic health disparities, but health disparities by weight status, health disparities by region, health disparities by immigration status, but especially with regard to health disparities by race, we unfortunately have lots of evidence about differences in the quality of care received within the healthcare system. The Institute of Medicine's Unequal Treatment Report documented many of those back in 2003. And now, if we were to do the same kind of review and compilation, we would, instead of pulling together hundreds of studies, we'll be pulling together thousands and thousands of studies. But the second level are differences in access to healthcare in the first place. But I'm hoping that everybody listening to me recognizes that health is not created within the health sector. So there's a third level at which health disparities arise, which are differences in the conditions of our lives, differences in our life opportunities, exposures, and stresses that are making some individuals and communities sicker than others in the first place. And really, you could contextualize this as a pyramid, these three levels, or basically really better as an iceberg where the huge base, the hidden base, are the differences in the conditions of our lives that are making some people sicker. And then usually those people who've been made sicker are frustrated because of limited access to the healthcare system. And then sometimes even the lucky ones who get into the system are sometimes further injured because of differences in quality of care. So going back to this cliff, now understanding how health disparities arise on three levels, we are going to go back and recognize we're really not dealing with a flat two-dimensional cliff. We're actually dealing with a three-dimensional cliff. And in some parts of the cliff, there might be an ambulance there, but maybe that ambulance has a flat tire. So it's slow or goes off in the wrong direction. Or maybe there's no ambulance there at all, nor net, nor fence. And usually at those parts of the cliff, the population is being pushed closer to the edge. So now let's label these observations about the three-dimensional cliff with how health disparities arise, where the differences in quality of care are represented when the ambulance is there, but it's slow or goes off in the wrong direction. Differences in access to care are no ambulance, no net, no fence. Differences in underlying exposures and opportunities are represented by the closer proximity of that greeny population to the edge. Now that we recognize we're dealing with a three-dimensional cliff, a whole new set of questions arise. First of all, how did the cliff become three-dimensional in the first place? Usually because of historical injustices perpetuated by present-day contemporary structural factors. But given that the cliff is three-dimensional, we also need to ask, why are there differences in how resources are distributed along this cliff face? Why are there differences in who's found at different parts of the cliff? Why are the oranges back here in a way and the greenies being pushed closer to the edge? And when you start asking and addressing those kinds of questions, you are doing something that differs from addressing the social determinants of health, which I described as addressing the context of our lives, addressing poverty, adverse neighborhood conditions, moving the population away from the edge of the cliff. When you start talking about systems of power that can differentially distribute resources and populations, we're now describing what I call the social determinants of equity or inequity, or systems of structured inequity. These systems of power that include racism, sexism, heterosexism, economic systems like capitalism, and all of the systems associated with weight bias and discrimination and all of that. These systems of structured inequity, which here I'm describing as the social determinants of equity or inequity, are a separate thing in and of themselves. And so I've distilled three dimensions of health intervention. The one dimension along the edge of the cliff is where we can display our health services, our ambulance, net, fence, our curative and preventive health services. But if we just focus there, you can overwhelm any system, even when we get to universal access to high quality healthcare, which is an edge of the cliff conversation and which we must strive for, because that's how a civilized society values all of its people equally. But even when we get there, we can overwhelm any system if everybody's pushed up against it. So we must move into that second dimension, which I can display in a flat plane, address the social determinants of health. We must address adverse neighborhood conditions, poverty, and the like. We must move the population away from the edge of the cliff. But if we do that, if we're about moving the population away from the edge of the cliff without recognizing that we're really dealing with a three-dimensional cliff, we are at risk of moving some of the population, but not all of the population, and actually making health disparities worse. We must acknowledge and address the three-dimensionality of the cliff, address racism, sexism, heterosexism, all of these systems of structured inequity, if we're going to achieve social justice and eliminate health disparities. So very quickly, here's some questions. If this is a useful framework, why are we spending so much time, money, energy on ambulances at the bottom of the cliff? If this describes different levels of health intervention, and if furthermore, we actually believe that an ounce of prevention is worth a pound of cure, and that the cynical answer is there is a lot of money being made down there. There's a lot of money being made in gastric bypass surgery for obesity. There's a lot of money being made on ambulances at the bottom of the cliff by healthcare systems and health providers, medical care, medical device companies, pharmaceutical companies, and the like. But that is the most cynical and apparent answer. But the deepest answer is that in this country, we are so narrowly focused on the individual. We don't even recognize that somebody has fallen off the edge of the cliff, or has a health problem until they fall off the edge of the cliff and either are caught in our nets in terms of school screening, BMI screening and the like, or fall to the bottom and we have to scrape them off for care, right? We are so narrowly focused on the individual, we do not recognize the proximity of populations to the cliff edge as a health problem. We don't even use aggregate measures of health like income inequality or social cohesion as health measures. Very quickly, on to the second of 3 questions I want to share with you. Here's the second question. Why are the greenies launching themselves over the edge of the cliff? This is the question people ask when they say, well, why do those people eat so much fried chicken? Or why aren't they reading to their kids? Or why do they eat this or do that? And this also is a reflection of the narrow focus on the individual, because when we are narrowly focused on the individual, it makes systems and structures either invisible or seemingly irrelevant. So the systems and structures that are pushing and keeping the greenies closer to the edge have been invisibilized. I could talk for hours on that one, but let me go to the third question, which most people do not ask out loud. But that is, this situation looks fine to me. What's the problem with a 3-dimensional cliff? And we act this out when, for example, we might live in a beautiful neighborhood and in the age when most of us were leaving our homes to go to work. We might leave our home, drive through a disinvested, segregated, oppressed, poor neighborhood and arrive at our lovely job and not feel a strong sense of urgency to do something about that disinvested, oppressed, poisoned neighborhood that we just drove through. And this reflects our endorsement of the myth of meritocracy, that if you work hard, you will make it, right? Now, I give you that most people who have made it have worked hard. Not everybody who's made it has worked hard, right? We have prime examples of that. But most people who have made it have worked hard, but there are many, many other people working just as hard or harder who will never make it because of an uneven playing field that has been structured and is being perpetuated by racism, sexism, heterosexism. All of these systems of structured inequity. When we deny the existence of these uneven playing fields, and we blame those who haven't made it for being lazy or stupid, right? And there are many ways to deny racism and to deny all of the weight bias systems and like that. I just want to say that one of the ways to deny racism is to say racism doesn't exist. Say those words. Another way to deny racism is to be talking about everything but. You could be talking about diversity, equity, inclusion, belonging, cultural competence, structural competence, disparities, disproportionalities, and the like. But if you talk about all those things and never say the word racism in the context of our widespread racism denial, we're complicit with that denial. So what do racism denial and the obesity epidemic have in common? What they have in common is a narrow focus on the individual, where this narrow focus on the individual makes us ignore systems and structures. It invisibilizes solutions, and it results in indifference and inaction in the face of need. I appreciate this opportunity to share these thoughts. I see that Nico came on, so I must have been just at the end of my time, and I am delighted to stop sharing my screen and engage in some discussion with you now.
Thank you so much, Camara. I mean, that was a presentation with lots of beautiful gifts. In fact, I'm only going to ask you one because we're a little low on time. But in your presentation, you gave us several definitions. The one I did not see was equity. Can you speak a little bit about what your definition of health equity looks like in the context of obesity?
I absolutely will. Thank you for that question. So my 3-part definition of health equity is, what is it, how do we get there, and how is it related to health disparities? I define health equity as assurance of the conditions for optimal health for all people, which differs from the Healthy People 2020, at least, definition of health equity, to which I contributed. I helped write that definition, but it differs because the Healthy People 2020, and I don't know if that was rolled over into Healthy People 2030 or not, but that definition said that health equity is attainment of the highest level of health for all people. I agree that that's our goal, but what bothers me about that as a definition of health equity is, what if we hit that last Sunday miraculously? Are we done? And I do not think that health equity is an outcome. I understand health equity as a process Which process? Assurance, which is actually one of the 3 core functions of public health identified by the Institute of Medicine, along with assessment and policy development. Assurance of what? Of the conditions for optimal health, the social determinants of health, if you will, for whom? For all people. That's what makes it equity. How do we get there? Achieving health equity requires at least these 3 things: valuing all individuals and populations equally, recognizing and rectifying historical injustices, and providing resources according to need. And how is health equity related to health disparities? Health disparities will be eliminated when health equity is achieved. Health disparities are the differences in the numbers of different colored bodies at the bottom of the cliff. For example, it's the differences in obesity prevalence, if you will, in different populations. Health equity is all the opportunity structures and investment and all of that that came before. So assurance, that focus on assurance, I would say, is what we need to do. And it's not an individual matter. Assurance is a societal matter. It includes government and others and communities and all. A lot of people can pile into assurance, but it is not an individual matter.
Terrific. Absolutely fantastic. Thank you so much for this presentation this morning. What a great way to kick off the workshop.